Good day, whatever the time of day is where you are, and welcome to this session on urban informality and life at the margin. We have 5 presentations from 4 countries in this session: Argentina, India, Ethiopia, and Bangladesh. The way this session will unfold is that we will view these presentations first. They are all pre-recorded. And after these presentations, we'll have a live Q&A session and a panel discussion. I request attendees to post their questions and comments in the live Q&A window as the presentations progress and as questions and comments strike you. We will take these questions and answer them in our Q&A session after all the presentations are over. If your question is directed to a particular presenter, please put that presenter's name before your question. If it's a general question to the entire panel, you can leave it like that. I am the moderator. My name is Josila K. Lakshmi. I'm a senior research fellow at the George Institute for Global Health in India. This slide has my photograph on it, and it also has my principal interests in research, advocacy, and teaching, which are health promotion, disease and injury prevention, and pluralistic medical society. But enough about me. We'll go on to the presentations. But before that, tips on using the platform for attendees. You'll notice that there is a support function on the top right corner of the page that you're on. And if you face any technical issues, you can access support. The Q&A, there's a Q&A session at the end of this session, but you have the live Q&A section on the screen where you should feel free to post your questions and comments. Again, reminding you that if it's directed to a particular person, please put that presenter's name there. For the best user experience, please view these sessions in full screen. You will have recordings of this session to view until the 31st of March 2021. And the browser zoom ratio of 67% is best for your viewer experience. Our first speaker is Alfredo Palacios of Argentina. He is the coordinator of health economics at the Institute for Clinical Effectiveness and Health Policy in Argentina, an economist and coordinator of health economics at the Institute. And he's also a professor in the master's degree in clinical effectiveness at the university. And his research interests are in health economics, applied microeconometrics, and impact evaluation of public policies, as you will see from his presentations. We'll move on now to the pre-recorded presentation.
Buenas tardes a todos y a todas. Mi nombre es Alfredo Palacios y es un gusto estar aquí. Hoy les voy a hablar acerca de mi trabajo titulado Vulnerabilidad social, exposición a factores de riesgo ambientales y acceso a servicios de salud, evidencia para más de 2.000 villas y asentamientos informales en Argentina. En primer lugar, es válido decir de que en la actualidad existe una preocupación creciente en Argentina acerca de cómo llevar políticas públicas y políticas sociales a las villas y asentamientos informales. Y estas villas y asentamientos se caracterizan por poseer una alta vulnerabilidad económica, marginación social y carencia de acceso a servicios básicos, los cuales lógicamente perpetúan estas vulnerabilidades. Y actualmente, si bien está un poco todo demorado por la situación del COVID, el gobierno argentino, particularmente en la ciudad de Buenos Aires, está implementando un plan para la reurbanización y la provisión de servicios públicos en este tipo de barrios. En este contexto, el objetivo de mi trabajo es tratar de proporcionar o proveer evidencia acerca de estos factores de riesgo ambientales en estos barrios informales en Argentina, y en segundo lugar, quiero analizar si estar expuesto a este riesgo o estos factores de riesgo ambientales tiene una correlación o no con una accesibilidad a los servicios de salud por parte de estos barrios. Los datos que utilizo para mi estudio provienen de una base de datos titulada Relevamiento de Asentamientos Informales de 2016, que fue llevada a cabo por una organización de la sociedad civil llamada Techo, Argentina, antes llamada Un Techo para mi país, y esta base de datos contiene información para aproximadamente 2.400 villas y asentamientos en Argentina, que dan cuenta de aproximadamente 650.000 hogares. Esta es una de las bases de datos más importantes para analizar cuestiones vinculadas a villas y asentamientos informales en mi país. Esta base de datos proporciona información acerca de características de infraestructura del barrio, exposición a factores de riesgo ambientales, como puede ser si el barrio se encuentra muy cerca a un basural o a un lugar de residuos industriales o a torres de alta tensión. Y a su vez recopila información acerca de la accesibilidad a ciertos servicios de salud, como la cercanía a un centro de atención primaria de la salud o a un hospital, o si una ambulancia puede ingresar al barrio ante una emergencia médica, entre otra información. Los métodos que utilizo principalmente son dos. Uno es un análisis de estadísticas descriptivas y en segundo lugar estimo modelos econométricos multivariados, tanto modelos lineales en probabilidad, modelos Probit y Logit. Y el objetivo de esta segunda aproximación es tratar de estimar la probabilidad de acceder a diferentes servicios de salud por parte de los habitantes del barrio, teniendo en consideración las características de la infraestructura de las villas y asentamientos, y por otro lado, teniendo en cuenta cuán expuestos están a factores de riesgo ambientales. En términos de resultados y vinculado a las estadísticas descriptivas, digo que en promedio cada villa y asentamiento está formada por aproximadamente 208 hogares y que en promedio estas villas y asentamientos tienen casi 30 años de antigüedad en el país, así que es un problema de larga data. Y por otra parte, con estas estadísticas descriptivas caracterizo la exposición de los barrios a estos factores de riesgo ambientales. Esto significa que si los barrios se encuentran a una distancia menor a los 10 metros de, como mencioné anteriormente, un basural, un lugar de desechos industriales o una torre de alto voltaje, y uno lo que encuentra es que en general una alta proporción de estas villas y asentamientos se encuentran expuestos a estos factores de riesgo ambiental. Por ejemplo, el 30% de las villas y asentamientos se encuentran cerca de un basural, o sea, a menos de 10 metros de un basural. Casi el 20% se encuentran muy cercanos a una torre de alto voltaje. Y en relación a la accesibilidad de los servicios básicos de salud, fíjense que aproximadamente el 40% de las villas y asentamientos no tienen acceso a un centro de atención primaria de la salud, es decir, que se encuentre a menos de 1 kilómetro o 10 cuadras. Y el 66% de ellos no tienen un hospital accesible, es un hospital que se encuentre a menos de 3 kilómetros o 30 cuadras de distancia. Y aún fíjense que en el 40% de los barrios una ambulancia no puede ingresar al mismo ante una situación de emergencia sanitaria. Esto es un panorama de estadísticas descriptivas de los barrios. Finalmente, en lo que respecta a los resultados del análisis de regresión, intenté sintetizarlo en este slide. Tengo múltiples tablas de regresiones que puedo compartir con ustedes si me contactan a través de mi correo electrónico, pero en síntesis puedo decir de que en general la accesibilidad a cada tipo de servicio de salud se encuentra positivamente asociada con el número de familias que viven en el barrio, la antigüedad del barrio y si el barrio es una villa, que en general en Argentina las villas están ubicadas como en centros altamente urbanos, a diferencia por ahí de los barrios informales o los asentamientos informales. Sin embargo, algo interesante que revela el análisis es que no hay una asociación estadística entre la accesibilidad a servicios de salud y la exposición a factores de riesgo. ¿Esto qué significa? Que quizás en un primer lugar uno podría pensar que si un barrio está cercano a un basural o a una torre de alta tensión o a una zona de desechos industriales, quizás podría tener más accesible distintos servicios de salud para poder responder a ese mayor factor de riesgo ambiental, pero en realidad eso no sucede, digamos. En general, encontrarse cerca de un basural, de una torre de alta tensión o de una zona de desechos industriales no garantiza que uno tenga accesible algún establecimiento de salud. Para concluir y presentar algunos elementos de discusión, quiero decir que mi estudio sugiere que las villas y asentamientos informales en Argentina están muy expuestos a factores de riesgo ambientales para la salud. Y aun cuando sucede esto, la accesibilidad a los servicios sanitarios es muy limitada a los barrios y no necesariamente se encuentra asociada con el riesgo ambiental al que uno está expuesto. Por lo tanto, tanto las dimensiones económicas, ambientales como sanitarias y la interrelación entre estas tres tiene que ser tenida en cuenta necesariamente para poder desarrollar políticas sociales efectivas para la población vulnerable. Les agradezco especialmente por su atención y en caso de duda o consulta, por favor, contáctenme a mis medios de contacto en caso de que necesiten más información acerca de mi estudio. Muchas gracias.
Thank you, Alfredo. We see from this presentation that the study shows that populations that are particularly vulnerable to exposure to primary determinants of poor health do not have routine support for healthcare to go with those determinants of poor health. We move on to the next presentation. The next presenter is Devaki Nambiar. She's the program head, Health Systems and Equity at the George Institute for Global Health, India. Devaki is a health policy and systems researcher with an interest in social inclusion, health equity, gender mainstreaming, and the right to health. She has a PhD from Johns Hopkins Bloomberg School of Public Health and carries out mixed methods research, capacity building, and technical assistance in many LMICs. And she's also received an Emerging Leader Award from the Royal Society for Tropical Medicine and Hygiene. We'll now move on to Devaki's presentation.
Hello, everyone. My name is Devaki Nambiar. And on behalf of myself and my co-author, Bincy Matthew, I'd like to present our work on healthcare-seeking trajectories and challenges of the urban poor in Delhi and India. And our focus is on the case of the homeless and healthcare-seeking migrants. Our story starts in 2013 with the National Urban Health Mission, which was established to improve urban health seeking about a decade and a half after the Rural Health Mission was set up. And the Urban Health Mission placed special emphasis on marginalized urban populations. And you can see various names listed here. And our emphasis, of course, in this study is on the homeless and temporary migrants. But I just want to also point out there are other populations facing a lot of vulnerability, such as construction workers and so on. Now, in 2013, a unique exercise was entered into where a technical resource group was created that visited no less than 31 different cities and towns across India and spoke to over 40 groups of different vulnerable people, individuals and groups, and identified a number of barriers in order to develop recommendations for how the urban health mission should be formulated. So these were some of the challenges that were identified. Being visible and eligible in the system was a challenge. There were many care needs that people had that they didn't even know about, and there was no follow-up for them. Lots of high hidden costs. Even while living in an urban setting where distance is not really an issue, location was still an issue. And there was an issue of social distance in the sense of not being able to access something because of your background, because of stigma and so on. There was also the issue of disrespectful behavior faced by people while seeking care, and then issues of corruption, malpractice, and of course the timing of health services was not suitable for many of the people that we spoke to. As a follow-up to this, about 5 years on, this study sought to understand what health seeking was like for vulnerable populations. It also sought to understand the perspective of health providers and develop recommendations, but this presentation will focus on the health seeking challenges and experiences of two populations of the urban poor. But overall, what we wanted to do was actually replicate the TRG methodology to the extent possible, in that we carried out individual interviews as well as focus group discussions. We also engaged in non-participant observation. And as I said earlier, the two populations that we were interested in is healthcare-seeking migrants, who are actually defined in Indian policy as people who move around in search of treatment and in search of getting better for ailments that they may have. And homeless are people who do not live in a census household and may have may have to survive living in staircases, on pavements, and so on. And these were the two populations that were officially defined in India that we were interested in. So we undertook to sample using convenience and criterion methods, so across genders, across backgrounds, across health conditions, these two populations. We got their consent, carried out recorded interviews that were transcribed, and recordings and transcriptions were kept securely with researcher-only access. Analysis was carried out using a grounded approach and data analysis software. We ended up speaking to 20 health-seeking migrants, of which 2 were female. It was harder for us to access female participants in our study, understandably, as people were in the process of seeking care and not feeling well in the first instance. We also managed to speak to 23 homeless persons in our interviews, of which 10 were women, and focus group discussions were possible only with male participants, ranging in group sizes of 7 to 10. Here's an example of the trajectory of care seeking of 4 different individuals who are health care seeking migrants. I'm going to focus on only the red. So you can see person 1 from Bihar has an accident, goes to a government hospital, then goes to a higher order government hospital, gets referred up, and then gets referred all the way up to the national capital. This is how the referral chain in India is supposed to work. But then you look at the situation of person number 2 from Bihar, who had a kidney problem, went to a private hospital, then got referred up to, well, probably didn't get referred, ended up going to a government hospital, and then not finding any respite there, ended up in the national capital seeking care. The situation of homeless persons was probably even more chaotic. You see person 1 and 3 here in the map that we've shown. The first person, person number 1, had an accident, ended up in an emergency ward of a government hospital, and then had nowhere to recover from his injury. He was referred through contacts and through NGOs to a recovery shelter run by NGOs, where it was discovered that this person had HIV, and then this person had to start ART treatment alongside injury treatment at the government hospital. So you can see this sort of circular piece for that person. Then someone with TB, who was only identified as having TB far down the line of his treatment, first went to a pharmacy, then went to a private dispensary, then went to a government dispensary, and was only diagnosed at a recovery shelter, after which he was in the process of seeking care when we spoke to him. So you see, this really reflects a whole lot of challenges that people would have had to face in the course of seeking care. And here's just an example of 4 of the main ones that came out in our interview. So for example, facility accessibility was marred by whether or not you had a contact. So you can be an ordinary person in line, but then some special connected person comes in and that person gets to go in. So this was definitely a challenge. Another was really the poor availability of medicines and lack of equipment at facilities, such that homeless persons had to go and get equipment for themselves from outside. And really the costs of those could pile up to being more than the amount that a homeless person can typically make in a year, being required for just one operation. And this cost issue was quite big. You can see that everything was costed. So there was a fee for outpatient care, and then another care, and every time costs would rake up. And this was a challenge as well. There were lots of delays and referrals and bureaucratic processes, in the course of which this health-seeking migrant from Bihar said that he hadn't even been able to have the operation that he needed to have a while back, 5 months prior. There were also unique challenges such as poor facilities and the hometown for migrants, which is why they would have to leave in the first place, and the fact that this introduced a lot of expenses. For homeless people, disrespect and discrimination was a major issue, as well as problems of comorbidities like addiction and challenges that women in particular faced, like violence and insecurity. So for example, having your OP papers eaten up by rats, or being attacked while you were sleeping at night in the course of getting care. These were the kinds of challenges you had. And of course, there was difficulty in giving identification papers while seeking care. So you can see that too little has changed since the time the TRG came out with its recommendations, and change has been very, very slow. And you can see that a lot of the challenges were shared across the 2 groups, where blue represents migrants and yellow represents the homeless. The rent-seeking bit and the consultation issue was something we observed that didn't come up in our interviews, but certainly these are challenges that are not likely to have gone away. Then, of course, there's additional expenditures, the issue of comorbidities, which is major in urban areas, particularly now in the context of COVID, and challenges of insecurity and violence. So really quite a depressing set of findings from our work. But we are nonetheless grateful that we had the chance to do this with funding from the Indian Council of Social Science Research and support of the Public Health Foundation of India. I'd like to thank all the people who supported this work, as well as our participants. And thank you for listening.
Thank you, Devaki and Binsi. This presentation really brought home the unpleasant truths of intersectionality and the coexistence of numerous adverse conditions that people face. We will go on to the next presentation, but before that, I'd like to urge attendees to put down their questions and comments in the live Q&A window with the presenter's name added if you want to ask a question to a particular person. We haven't received any questions so far, which is surprising, so please get on with asking questions. The next presenter is Muluken Gizao Turago. He's an assistant professor at Addis Ababa University in Ethiopia, an epidemiologist with special focus on NCDs, and particularly in cancer epidemiology, with a special interest in early detection of cervical cancer. He is actively involved in the cervical cancer control and prevention program in Ethiopia, and works on social determinants of health. And he's led a randomized control cluster trial to optimize cervical cancer screening in Ethiopia. We will now move on to his presentation.
Hi, this is Muluken from Addis Ababa University School of Public Health. I'm from Ethiopia. Today I'm going to present on perceived barriers to healthcare for residents in vulnerable urban center of Ethiopia. I have nothing to declare. As an introduction, Islam in urban setting are fast expanding, and a large proportion of urbanites are now living in slums with compromised provision of health services. In most developing continents, including Africa, urban setting inequities are far more marked compared to some rural settings. So when you compare to some rural settings, urban found to be more vulnerable for various health problems. In Ethiopia, along with the pace at which the country is urbanizing, inequality in accessing health services and the structural issues are creating large market disparities for residents, which results a wide range of health problems like due to urban poverty, poor sanitation condition, overstretched infrastructure, overcrowding, and social exclusion. Some of the factors for such kind of wide range of health problems in vulnerable urban settings. The Ministry of Health in Ethiopia has taken a proactive measure to ensure access to health service for all residents in urban settings through its Urban Health Extension Program, which has been established since 2009. Urban Health Extension workers or professions means who are by training are nurses are trained for a year and are expected to engage a household service in an urban setting. There is a paucity or there's evidence on identifying barriers in vulnerable urban center of Ethiopia. That's why we explore the barriers to use the health service in Islam urban setting of Ethiopia. As a method, we employed a qualitative study using in-depth interview and key informant interviews in 13 selected GSI program operational urban areas. We analyzed using thematic content analysis, and accordingly, we set out individual community and health facility level barriers as a main themes for this study. Just to mention very key findings, the first we established the barriers in different level, at individual level, community level, and at health facility level, just to see a barrier at individual level. These individual level barriers are associated with inherent factors such as limited awareness of the service and personal motivation to seek service. In addition, competing priorities and lack of money to spend on service affect decision to visit health facility. Moreover, these things are mainly associated with misconceptions in different vulnerable settings. So one of the participants said, I'm struggling to generate daily bread for my children and do not have time for a routine discussion with the health extension worker and follow her advice to visit health facility to get or check my pregnancy. For me, I wish this pregnancy had not happened, but I'm fine and should take it to term. There is no need to visit health facility since I'm fine with it. In line with this, one urban health extension professionals also emphasize that those who live in a slum neighborhood struggle for survival, and they don't care much about visiting a health facility in connection to pregnancy or after delivery. If they visit health facility, it happens only after it gets worse. They also complain to have no money for laboratory tests, drug, and even for transport. Whereas at community level is mainly associated with like understanding, knowledge, or it depends on the extent of awareness and the religious beliefs. One of the participants from the study mentions that culturally women are not encouraged to get out of home right after delivery. There is an established belief that women and the newborn should stay away from sunlight, wind, and cold for at least 12 days following delivery. This has affected our postnatal care indicator, not only in vulnerable section of urban area, but also in the better off part of the town. But such kind of problem is highly prevalent or highly prevalent in a vulnerable section of this urban settings. Just to mention few health facility level barriers, all participants across all the study setting anonymously reported that a shortage and a lack of diagnostic facility in government health facility beside prescribed drugs are often not available in the health facility. One of the study participants said health facilities were found to lack necessary supplies. If health facilities lack required diagnosis and treatment supplies for pregnant women, it not only affects subsequent interest to visit the health facility. The health extension workers lose confidence in our service provision and trust from the public. So, yeah. So, as a conclusion, this study clearly shows that average or aggregated health indicator in urban setting given an inaccurate impression, since there are specific sections in urban settings that are much more affected. While health facilities are relatively easy for urban clients to access compared to clients in rural setting, the use of such service is not at the expected level. So this study showed that multiple barriers that operate at different level, which affect community visit or use of health facility. So finally, we would like to recommend that the health sector and health development partners are expected to give special attention to slum areas in urban setting through multifaceted intervention, considering individual, community, and institutional level barriers or problems. These are some of the cited references in this presentation, and thank you very much for your attention.
Thank you, Mulukan, for this presentation that highlights the interrelationships, the complex interrelationships, in fact, interdependence of among the factors, policy factors, individual and community factors in the success of a health program and in fact in population health. We move on now to the next speaker, who is Antara Ray Chaudhary. She's a research associate at the Indian Institute for Human Settlements, a graduate of economics and development studies. She practices survey and qualitative research methods, and she has 4 years of experience in research and practice projects that seek to understand the organization of work and social protection in women's informal work in large Indian cities. She's interested in class and gender analysis of women-dominated work, as we'll see from the study that she will present now. We'll move now to Antara's study.
The work I'll present today is a team effort with my colleagues at IHS, Aditi Suri and Gautam Han. I'll use this time to share the study rationale and findings in brief and spend more time on the propositions. We will look at challenges to improving women's employment and childcare in Indian cities. And specifically, we pick up the case study to look at exclusive breastfeeding and how informal employment shapes exclusive breastfeeding. To begin with some context as to why this work is essential, I want to mention a recent systematic review on health inequities in India by Gaitonde et al. In 2018. It reveals that very few qualitative studies explore mechanisms and pathways that talk about how health inequities come to be in different settings. This is because there's a paucity of research that looks at different kinds of vulnerable groups and which looks at interventions about what works and what doesn't work. The work that I present from addresses 2 of these gaps. Firstly, many studies that look at health in the urban do so from the place of residence, that is slums, informal settlements. While it is an essential entry point, it can invisibilize some vulnerabilities or pathways to inequities. So the intention to look specifically at risks at the intersection of livelihoods and health, something that is in spotlight today because of COVID, motivated us to look at health in the cities from the entry point of the place of work. We specifically look at women's employment in cities here. Secondly, other than looking at the barriers and enablers, we also focus on discussing and suggesting the pathways for intervention with both our study respondents and our research audience. A little bit more on the context. In India and globally, a majority of working women are employed in informal economy, which is marked by lack of legislated social security, low and irregular income, and non-standard work employment conditions. On exclusive breastfeeding, it is identified as a cost-effective and key measure against leading cases of morbidity and mortality for children under 5. In Indian cities, the exclusive breastfeeding rates are at 55% as of 2016. So these women who are in the informal economy lack the workplace protection that allow for maternity leave and other infrastructure related support that could help them breastfeed in the first 6 months. So these women, in fact, face challenges in 3 directions. That is, they need to earn income for their households. They need to provide optimal care for the children without having adequate support in terms of maternity protection. And they need to care for themselves, which brings us to our research query. This was a formative study, an exploratory study to yield evidence on the conceptual and empirical pathways to improve maternal and child health among informally working mothers while securing their livelihoods. We do so by looking at the current knowledge and practice, how they navigate exclusive breastfeeding, a time-sensitive activity, while managing their work. And lastly, we analyze this data to see how the conditions and nature of informal employment shape their breastfeeding knowledge and especially practices. Briefly on the study design, this was conducted between February and May 2017. It was exploratory. So we followed a non-probability sampling. We partnered with a membership-based organization called SEVA, Self-Employed Women's Association, for site selection and recruitment in New Delhi, India. We worked with 4 sectors of work: home-based work, barter work, street vending, domestic work. Some of the key findings are that there was overall a lack of effective knowledge, that is, knowledge that these women could use to suit their challenges. There was a competing priority between livelihoods and public health guidelines for optimal childcare. And thirdly, there was little support at work and home to manage exclusive breastfeeding while working. To summarize, most of the women knew that they must breastfeed, but only few of them could actually breastfeed. 60% of the women had to return to work within the first 3 to 6 months, reporting irregular income for their husband. Successful exclusive breastfeeding was possible, but only when they were doing home-based work, which is also one of the least paying forms of work. This brings us to the propositions or pathways of interventions that we propose. This is a framework by Rollins and his colleagues, which look at enabling breastfeeding, how one could enable breastfeeding. We use this framework to suggest some of the pathways. Firstly, we talk about increased temporal and spatial proximity. So all of the 3 successful cases of exclusive breastfeeding were possible in home-based work, which highlights the significance of proximity between a mother and a child, something that's intuitive but important to highlight. While home-based work made it possible to exclusively breastfeed, it was also the least paid, thus bringing livelihood in directly against childcare. One of the key barriers to maintaining such proximity is early return to work. Now, informal employment in the informal economy do not give maternity protection, as mentioned earlier. So then what could be the other ways to operationalize delayed returns to work? We suggest income compensation to be more likely to be effective, because in informal employment, there are either self-employed or there are several employers. So it would be hard to operationalize maternity leaves. Our South African respondents in a partner study were found to have a longer return period, citing child support grant as a principal means of income compensation. Now, the popular public health construction of advice around exclusive breastfeeding doesn't acknowledge and accommodate the time, poverty, and triple burden of work that women face in informal work. But thus, it brings us to a third pathway, which is effective knowledge that is engaged in deeper understanding of the reasoning and implication behind the 6-month exclusive breastfeeding recommendation. While we were presenting this study back to the participants, when the mothers were told about the scientific reasons behind exclusive breastfeeding, many of them explicitly expressed that if they had known the reasoning before, they would have attempted to do it better. The fourth pathway that we discuss is about problem solving. So despite having knowledge, we observe that it is not certain that one is able to practice it because of one's unique challenges. The working mother is always facing competing needs on her time and making several choices to manage livelihood, childcare, other household responsibilities. And the choice to deprioritize any of them puts her through a lot of stress. Thus, to make informed decisions, women need a safer environment to help them balance the competing forces, which brings us to our fourth pathway, which is problem solving, improving the problem solving capacity and agency. And the last one is about home and workplace conditions. That is, of the women who returned to work before the child was 6, perceived the place of work to be unsuitable for a young child. Some of the perceived threats were traveling with child over short and long distances, harsh weather environments, constant need for attention while managing work, no place to rest the child, and so on. And when they were left with a secondary caregiver at home, they could not be sure that the child would be looked after at the best. Even at home, there was likelihood of an open sewage near the house, which compromised the quality of potable water, had created irregular water supply, which again introduced the possibility of infection from water. So with this, I would like to close the presentation. And I would just really want to say that we are all aware of the positive impact of women's employment at the level of an individual and a community on both social and health outcomes. So the health systems and policy action can support such call for women's autonomy by making sure that when we're thinking about improving maternal and child health, we improve the ability of individuals and families to secure both livelihoods as well as childcare. And not forget that mothers are also workers. Thank you.
Thank you, Antara, for this presentation that focuses on a population that has the weight of multiple responsibilities, but very limited autonomy in order to carry out those responsibilities effectively while protecting their own health. Your presentation also provides some hope and some direction in that you've proposed many interventions, each of which addresses various aspects of the individual's life. So we can take it forward to the happy balance of employment and health. We'll move on now to our last presentation for this session. And this is a presentation by Basira Akhtar, who is Assistant Director at the BRAC James P. Grant School of Public Health, BRAC University, Bangladesh. Basira is a public health professional with over 11 years of experience of implementing community-based public health programs and research in rural and urban Bangladesh. Her areas of interest are reproductive, maternal, and child and adolescent health and nutrition, and health systems and healthcare and humanitarian settings, participatory action research and implementation science. As we'll see from this presentation that we're going to
Hello everyone, this is Basira Akhtar from BRAC James P. School of Public Health, Bangladesh. Today I will be sharing learning from one of my research projects named ARISE, which I'm currently working with. ARISE is a multi-country research consortium established in 2019 in partnership with 11 organizations in Bangladesh, India, Kenya, Sierra Leone, and UK, with a common goal to improve health and well-being of marginalized, poor people living and working in urban informal settlements in lower and middle-income countries. These are ARISE partners across globe. Like all other countries, urbanization is an inevitable phenomenon for Bangladesh. Every year, millions of people migrate from rural areas to big cities and towns in search of better livelihood, education, and healthcare. Dhaka, the capital of Bangladesh, is the largest hub of this migrant population. Currently, about 18 million population living in Dhaka city, and among them, one third of them living in informal settlements or slums, referred as Bosti in Bangla. Inequity and vulnerabilities are the key characteristics of these urban informal settlements. Now let's watch a short video we produced from our project on the living conditions of urban informal settlements.
Dhaka, the capital of Bangladesh, is the destination of 300 to 400,000 migrants, most of whom are from poor rural backgrounds, coming in search of a better life. There is a housing issue where most of the urban poor have ended up living in slums that lack basic facilities. In Bangladesh, slum settlements tend to be built on vacant government or private land. Many slum settlements are built on polluted spaces, exposing residents to industrial waste and all sorts of horrendous conditions.
ভিতরে একটা ভয় আছে কোন সময় সরকার আইসা বইলা দেয় যে কালকে আপনাদের এখান থেকে চলে যেতে উচ্ছেদ করা হইব তখন আমরা এই বাল বাচ্চা নিয়ে কোথায় যাব
Sounds like the most basic amenities like water and electric supply.
বিদ্যুতের লাইনও আমাদেরকে দেয় না আমরা যে বিদ্যুৎ ব্যবহার করি সেটা অবৈধভাবে কারণ ওয়াসা আমাদের ভিতরে লাইন দিবে না কিন্তু 8 টাকার পানি আমরা খাই এখন 35 টাকা দিয়া
এখানে ওই যে আমাদের এনজিও পানি লাইনটা দিছে না অনেকের ঘরে ঘরে কিন্তু ড্রেন করে দেয় না তারে আমরা কি সমস্যা হইতেছে তার জন্য
টয়লেট আসলে আমাদের মহিলাদের জন্য অনেক সমস্যা অনেক সময় মেয়েরা আসতে চায় না বদলি হাতে
Furthermore, the slum dwellers lack various important fundamental rights, such as provision to healthcare services.
আমাদের একটা রোগী যদি রিস্কা দিয়ে নিতে যাই তখন রিস্কা যখন রোগী আরো অসুস্থ হয়ে যায়
প্রথম অসুখ বিষয় হলে কবিরাজের কাছে আসে তারা তাবিজ দেয়
3000 4000 টাকা জোগাড় করা বড় কষ্ট তো কাজে কি করি হাতুড়ি মার্কা ডাক্তারের কাছে যাই যাই ওই ব্যথার ট্যাবলেট এমনি কইয়ে দেয় 2-4টা করে আইনা খাই খাইলে কিছুক্ষণ একটু ভালো থাকে কিন্তু পরক্ষণে সেটা খারাপ পরিণত বেশি হয়
These unfortunate people remain vulnerable to various forms of violence. Drugs and gambling prevail to be the most common social problem.
আর এই কথা বললে কলজা ফাইটা যাবে এই ছেলেরা সব নষ্ট হয়ে গেছে যত নিশা পানি আছে খায় নিশা পানি বিক্রি করে আমাদের মত মেশে বিক্রি করতেছে আবার আমাদের ছেলেপেলেরা খাইতেছে ঘরে যাবে করে যাচ্ছে
বেশিরভাগ সময় বস্তিদের মেয়েদের ছোট থাকতেই বিয়ে হয়ে যায় 10-11 হলেই বিয়ে হয়ে যায় কেন আমাদের বস্তির ছেলেরা তো ভালো নাই টিটকারি করে পরে মেয়েদের নিয়ে ভাগায় চলে যায় মানে খারাপ কথা বলে তাই জন্য বিয়ে দিয়ে দেয় বাপ মা তাড়াতাড়ি
This also pushes the future generation towards the pit of despair that the current generation are already suffering from. In spite of all these, Hashantek is one of the most well-developed slums within Dhaka. This only leaves us to wonder the sort of hardships inhabitants of countless other slums endure after waking up every single day.
So in 2019, we did a initial scoping review to understand the dynamics and challenges of informal settlements in Dhaka city. We conducted a series of informal discussions with city authorities, urban experts, and informal settlement dwellers. We also visited some slums in our study sites. And we also conducted one stakeholder consultation workshop and did data scoping review. As you saw in the video, that the urban slums in Bangladesh is very dynamic. There are geographical locational differences. There are some slums which are very stable. There are some slums which are comparatively unstable. There are people with there are diversity within the slums where there are extreme poor people and there are also comparatively better off people living together. The infrastructure and functionality of governance of public services and facilities are very poor. People are mostly depend on informal service providers and also private sectors for basic services, including health, water, sanitation. And the urban informal governance actors and gatekeepers are the key governance actors in the informal settlements. Inequities exist in every aspect, and vulnerabilities and marginalizations are very multidimensional. The challenges that we have learned that there is no comprehensive urban strategy in Bangladesh, and the current health and urban policies and strategies have not included informal settlements as their priority area. The residents are considered as burden and barrier for urbanization and only remembered when there is election. There are lack of government stewardships. The local governments are responsible for providing primary healthcare services, whereas the Ministry of Health and Welfare are responsible for providing secondary and tertiary level health services. But unfortunately, the secondary and tertiary level services are predominant by private sectors, which are unaffordable and inaccessible to the poor people. There are lack of coordination between all sectors. There are many organizations are working in the slums, but they are mostly working vertically. There are lack of timely, accurate, reliable data sources, and the the National Health Information Systems doesn't have the provision for including NGO data. The key lessons that we have learned from this exercise is that the informal settlements are still unpacked and is not a unidimensional box. It's very important to understand the diversity, the complexity of informal settlements and design solutions accordingly. A comprehensive multidisciplinary approach is very essential to solve these multidimensional problems of the slums. Both humanitarian and development approaches are very much in need, because the complexity is not less than the humanitarian context. In the resource-conscious country like Bangladesh, multi-sectoral collaboration and strong coordination between different sectors are very important to ensure the health and well-being of these poor people living in the slums. We acknowledge the support of Global Challenge Research Fund, our donor, and UKRI. Thank you all.
Thank you for this presentation, Basira, which sheds light on the diversity in slums, not least in the complicated governance structures, formal and informal. We will now move to the question and answer session since we finished with all the 5 presentations. We have a few questions, and I noticed that we have questions from panelists to other panelists. So we'll move to these questions. I think we'll go in the order in which these questions came in. So the first question that came in was from Shrutika, and it is a question to Devaki. Could you please elaborate a little on why FGDs? Oh my God, I've lost it from here. Okay, her question was on why FGDs could be conducted only with males, and why there were so few females in your interviews as well. Devaki, you need to unmute. Okay.
Okay. Binsi, did you want to take that? So I just want to acknowledge Binsi, who is my co-author and the main field researcher for this, is also here. As you can see, I'm apropos with the theme of this meeting, I'm currently breastfeeding. So if she could just answer that, that would be really great.
Yeah. So, okay, so I'll tell you, for the group of health migrants, we mostly individually approached them. So we never found enough people at the same time. Like in the case of homeless people, what happened was that we connected with them in a shelter where NGO was providing services to it. And since we had good relations with the NGO, it was easy to kind of organize them and have an FGD. So that made it simple, easy in the case of homeless males. In the case of homeless females, we again did it we did visit a shelter again, but then there was an overwhelming number of women with mental health problems. So we were not certain if it was ethically appropriate to approach them to participate in the study. That was one concern. And even when we went to the streets, we did not have enough number of males or females to do interviews in the streets. So that was the case of homeless males and females. So that was a challenge we faced with organizing FGDs with homeless females. So in the case of health migrants, what happened was that, yeah, the reason why we had a very hard time approaching female health migrants, and they were usually more skeptical than male health migrants, as well as the entire male and female homeless participants for interviews. So it was very difficult to, I mean, I don't know why they were not comfortable talking to us. Maybe they were skeptical because they were from they were not from the city. So I assume that was the reason why they never trusted us. So even if health was a concern, it was like the fact that they were feeling sick. Male health migrants did not probably face that kind of apprehension that, oh, this is a stranger, who's just approaching us for an interview. So I think both Dian and I had faced that issue when we once went to do interviews with female health migrants. And then the case was that, yes, again, we didn't have that kind of relationship where we could gather so many people among the health migrants to do the interviews. Yeah. As FGD, sorry. Yeah.
Thank you for that explanation, Binsi. Let me ask a follow-up question to that.
Yeah. Okay.
Did you approach these people through some organization? You talked about shelters. So did you have this kind of a conduit?
We were in touch with an NGO which provides services to homeless people. So yes, ethically, it's an ethical requirement that we kind of we approach people where an NGO provides services. So even in the case of streets, we kind of in the case of streets, we per se did not need the help of the NGO, but we at least made sure that in case there were participants who needed care at some point, even when I'm doing an interview on my own, we could connect them to the NGO in case they needed some health service. Yeah.
Thank you. We'll move to the, Devaki, you want to add to this?
There are also some NGOs that were operating in the tertiary level facility where we sought a sample of health care seeking migrants. And so we took their help in some parts, but we also tried to approach again, knowing that we could refer patients to the NGO, we also tried to approach individuals separately. But as you can imagine, just the way, when you're seeking care, you're sitting in a kind of camp or you're sitting on the side of the road, that really doesn't lend itself to kind of setting up an FGD, if you can imagine, right? Because people are just they're there for their care. So it's tricky and really a reflection of our findings as well.
Yeah, thank you. We'll move on to the next question. And this is a question to Antara from Anika. Did you also look at nutritional status of the mother and ability to breastfeed, keeping in mind the possibility of undernutrition being prevalent among women involved in informal work?
To that, we didn't look specifically at the nutritional status of the mother, no, in this study. Though something that was coming in our interviews was that, one, there were a few complaints about not having enough breast milk at birth or drying up in a few weeks after delivery, in which case they were suggested these pumps at the local pharmacy store, which also didn't help them adequately. Secondly, they would themselves complain of not getting enough rest between breast milk feeding, or in case in just the normal routine of the day, which we assume also has a negative effect on the ability for the woman's body to produce breast milk. And throughout these interviews in Delhi and also in other cities, the concerns of sugar and BP have been repeatedly brought up in interviews or conversations about health. So, so formally, no, we didn't capture nutritional status, but these are some of the anecdotal things that have been coming up in our interviews in the last couple.
I just want to elaborate on one point that you mentioned, concerns of BP and diabetes, you said, among the breastfeeding women?
Yes, also.
Okay. Okay, you have two more questions. One question is, what was the role of SEWA potentially in providing supports for working mothers?
So directly, they would usually help in being the referral system to telling them which is one of like the best government hospital to go to, or if there's no government hospital in proximity, or if they are seeking a private care because they don't trust the hospital for certain reason or it's far enough. So they'll connect them to like the most cost effective or trustworthy private care clinics. There were also sometimes there were like information and communication sessions, but I would see that all of like the referral to an ICDS, an ASHA or a hospital is intervention. Or the mothers, or especially the younger mothers who are having the first or second child, they are not in touch with these as much because as Joycela said, like they don't have that kind of autonomy over their own time or who they talk to, what kind of like communities they engage with. It takes a little while for them to really get integrated into these systems. And by the time they're already past their, they've had their deliveries and their kids are already grown up. And secondly, the time itself, even if they have autonomy, like to give that kind of time to have that engagement was itself very difficult for both the seva itself and the mother. They want to get in touch the time they could get in touch with.
I have another question before we leave Antara's study for a while. You spoke to women, and these were women-dominated professions, as you mentioned, these occupations. But did you come across men in these, I mean, minorities possibly, but did you come across men in these occupations, and did you have any discussions with them on the priority and support for maternal and child care? So did you canvass men's views on breastfeeding?
So in all the 4 sites that we did our research in these 4 sectors of work, we had a focus group discussion with 5 to 8 men in each of these sites to talk to them about what is their knowledge of breastfeeding and what are their perception of women breastfeeding in their workplace, just to get a sense of what they are thinking about all of this. So we were surprised, but shouldn't be, that so the men were completely it is. And there was also this sense among them, don't sexualize a breastfeeding mother in public or in their workplace. So there was that understanding that it's something that needs to be done and there's not enough support or care for it. But a similar kind of, it wasn't echoed when we talked to the women about breastfeeding in occupations such as street vending, which is more public and it has a more mixed sort of crowd around. Domestic work is still in a private space. Home-based work is extremely private in that way. But street vending mothers, neither had time nor did they think that like, that kind of an atmosphere was very friendly. Although there was also like the idea of shame was also like not very key. The time and the like the activities created a larger reason for them not being able to do it. They said chunni laga ke to we can still cover up and like we can handle the shame of it. But so to answer specifically in terms of priority, I think there is a sense among men also that they prioritize breastfeeding, but in general amongst everybody, and I think this goes across classes, the understanding of why breastfeeding is given so much importance is not very clear amongst population. So it's not seen as a very valuable activity in itself if it comes in conflict with any other responsibility of a woman.
Thank you. There's a question for Mulukan from the panel. Is it feasible for extension workers to carry out home visits instead for postnatal care?
Yeah, thank you, Ms. Chair. I think let me explain about a little bit about health extension program in our country. Health extension program is one of the flagship programs in our healthcare delivery system. We have rural and urban health extension workers. Their role is mainly to provide preventive and some curative services. I think since this program came to effect, the accessibility, especially to hard-to-reach places, and awareness of the community towards to health in general have been improved. So there have been several studies conducted to check the feasibility of health extension workers. So yes, it is feasible, and it is feasible to undertake home visit at the community level. Thank you.
Thank you for that answer. We have questions for Basira. The main reason for continuing to seek care was lack of diagnosis, provide a referral to find out in the city, lack of relief or worsening of status by way of navigation. Oh, sorry, that's not a question, that's an answer. Okay. Okay, so let me go to the question. A question was asked of Devaki and Binsi, and that question is, I'm sorry about, okay, can you repeat that question, Devaki, and give your answer?
Sure. So this was a question from Basira, I think, about the care seeking and referral pathways. Her question was, how do people navigate this and how do they make the decisions on where to go and where to seek care? And I'll just start us off, but Binsi can add. So our response is in the chat box. The main reasons is lack of diagnosis. So, not really receiving a diagnosis and the provider or wherever they sought care saying, go find out. Or in one case, it was an accident, right? So the person was taken to a government hospital. But there were other reasons also, like lack of relief, worsening status, so just really not having the health issue resolved. I think we noticed with a lot of folks in urban areas, particularly the urban poor, health is not a priority until it's really an emergency, and I think for many people, when things were just really getting bad and making it difficult to continue your daily life, people are trying to seek care. The sad thing is that for health-seeking migrants, even that process makes it hard for you to move on with your life because it reduces your earning capacity and all of that and takes time and so on. And in terms of navigation, we found, as I think others have also seen, and also as you have pointed out in the case of Bangladesh, where there are some NGOs providing support, there is some kind of navigation that happens in terms of figuring out where to go, where you think you'll probably be able to get decent care, respectful care, or care with follow-up, subsidized care, those kinds of things. Anything to add, Binsi?
I guess I also felt that her question was veering towards how the care pathways actually, how the care seeking actually happened. So, I mean, I don't want to take up a lot of time, but in the case of health migrants, it was usually they were either not satisfied with the private care providers in the state where they were. This, for instance, in Bihar, and then they were sometimes referred either from a private care provider or a government health provider to this government hospital in Delhi. So that was mostly the case of health migrants either taking a formal referral channel or being asked by the relatives to visit this hospital in Delhi. Then in the case of the homeless people, it varied. Sometimes they just happened to be in the space where there are shelters, and they know that they can probably take the help of the NGO to seek care. But again, it was not easy. It's very complex. There are the NGO also faces all the challenges that any homeless person would in getting care for them, because it's a government hospital, and then there were all these additional challenges that TB patients face. Like, they sometimes dropped out of TB care, the medication that they were being given, the correct medication that they were being given for TB. They dropped out, and then they again returned to the recovery shelter because their health had worsened, and then they realized that they really did need medical care. So it was, and this was again their care seeking was preceded by misdiagnosis, being given the wrong medication until they found the right medication, that the right diagnosis, that it was in fact TB and not something else. Yeah.
Thank you. I have one question for Basira before we move. Basira, you mentioned that slum populations are a vote bank for politicians, local politicians. So that got me thinking about, do they have some kind of documentation in order to vote, like a voter ID? And what kind of documentation actually helps in accessing support for health and well-being? So if they have some documentation that allows them to vote, can they also use that or similar documentation to access healthcare, to access subsidized foodstuffs, things like that? Basira, you're okay. Now you're unmuted.
Yeah. Sorry, Jackie, can you please repeat your question?
Yeah, you had said that slum dwellers are a vote bank for politicians. So they don't really care beyond getting the votes of people who live in slums. So how do they vote? Do they have documentation in order to vote? Do they have a voter ID? And can they use such documentation as a voter ID or something else like a ration card that we have in India, but I'm not sure about what documentation you have in Bangladesh. What do they need in order to access various kinds of government support for subsidized food or free healthcare and so on?
Thank you, JK. So in Bangladesh case, yes, they do have voter IDs, but that's also depend on where they have registered as a voter. So the support they're getting that also depend on where they're registered. So for example, if a person is registered in a village as a voter, but migrated to an urban slum, that person usually left out from the support system because that person is not a voter of that area or urban areas or Dhaka area. So that is one of the challenges that we have found from our research. And in terms of the other getting other government facilities in Bangladesh, there is no such system actually in place where the people are enlisted and then they're getting some kind of ration cards or some kind of other supports. This kind of system is not in place. However, for some specific group of people, for example, people with disabilities, so there are some options that they will get some allowances from the government. But here again, as people who are not actually enlisted voter of that specific area, they're often actually left out from availing those services. So this is very unfortunate, though they have legal documents as a voter, but due to the registration, the place of registration, it's actually hampering the service they're supposed to get from public system. Thank you.
Yeah, thank you for that. We are getting close to the end of the session. We have 7 minutes. And I would like to ask each presenter, and when I say each presenter, I think it's only fair that Devaki and Binsi should just get one vote here. So each presenter, like from each presentation, I'd like to ask each presenter to come up with one actionable recommendation that you think can be put into action immediately. Like, what is the top recommendation that you would make to policymakers or researchers or implementers or whoever it is? Just give me one top thing that you feel should happen as a result of your study. So we'll start with, shall we start with Muluken? He's top on my screen here.
Sure. Yeah. So my top recommendation is, when you see the urbanites in general, it sometimes is confusing or misleading. So I recommend subsections like those Islam areas must get an attention or special attention. Otherwise, the average or aggregate indicator would result like a misleading information or misleading picture of the city.
Yeah, thank you. We'll move to Basira.
Thank you. So from our research, I think we think that it would be, it can be actually, it's doable to link the community with the local representative of city authorities, for example, the ward councillor or the elected members of that specific area. So because they can easily actually reach those people. So if the linkage can be built between the community and this local level governance actors, then the community can easily raise their voice and their voice can be then translated and also transmitted to the city corporation level, as the local public authorities are actually representing the city authorities or city corporations. So in that way, their voices, their needs, their priorities can be actually transmitted to the actual planners, and then can be included in the city development plan. Thank you.
Thank you. Devaki or Binsi, who wants to?
She lobbed this at me. So I'm going to suggest something that actually came up in the COVID context and has already succeeded. So we're hoping that it has wider, is recommended more widely. And that's the ID proof thing. And this is following from what Basera and you were talking about, you know, the portability of the ID proof becomes a big issue. And for homeless people, for instance, during COVID, they were not able to get their tests done because they didn't have this particular kind of Aadhaar ID. And so and then there was an appeal made actually to the health minister in Delhi, and that requirement was removed. And it was like over a week that this happened. And I feel like more broadly, there needs to be a clearer understanding that for the system to see a person, it's not the person's responsibility, it's the system's responsibility. So there has to be something in the back end of the health systems that sort of categorize and sort of take stock of who is coming to the health system, not them having to carry this Aadhaar card or that Aadhaar card. They should come in with any card, maybe even a letter from an NGO, but the system should be able to see them. And that's, I think, very critical.
Thank you. Antara? Yeah.
I know I have just one, but I'll talk about two. So one of them is there has to be stronger advocacy along with designs for a maternity, for an income compensation for the loss in employment of jobs from the last month to first 6 months of delivery, to make sure that their livelihoods don't come in conflict with the mother and child's healthcare, and the mother and child's healthcare don't come in conflict with women's own employment itself. So we don't, like, we find a strike between the three. There has to be adequate entitlement, because currently the amount is too less and it's given for a period of time that's not adequate, and it's only given for the first child. The second set is, it's part of like a whole set of recommendations from the work of Deepa Sinha and other scholars who talk about building on the existing infrastructure of ICDS, the Integrated Child Development System in India, so that it creates a more meaningful kind of a social care system. And one of the very basics that can be done is extending the ICDS working hours itself to cover the whole day, so that it becomes a meaningful creche option for working women. This is something that's already been done in Mexico and Chile, and it has shown positive impact on women's employment.
Thank you. We've come to the last 2 minutes, so I'm just going to summarize what we've seen and discussed all this time. We viewed 5 presentations from diverse settings. They used diverse methodologies, and the findings all converged on a few key messages, which are crucial for researchers and implementers, and most of all for policymakers. And those messages, as I could see them, were heterogeneity. So slums, the urban informal settlements are not monolithic. They are heterogeneous, and they should be viewed as such, as reflected in your appeals for disaggregation of data and so on. And there is this imperative for customization. We need to understand, identify the differences, and tailor what we do to those differences. The need for provision and support for various social determinants of health, not just healthcare when everything goes wrong, and the need to keep intersectionality in focus. So a person is not just one category of disadvantaged, a person may be multiple categories of disadvantaged. And we also saw that there are gaps, there are unfortunate, sad gaps between the stated intentions of various policies and programs and the actual actions that take place. And so there is need for continual monitoring and correction of these programs, the way they're implemented. And I'll just repeat your recommendations: disaggregation of data for accuracy of the picture that we get and work on, the link between communities and local governance actors to enable their voices to be heard and their priorities to be worked on, the ownership of responsibility by the health system, not the onus on people to produce documents and be eligible for care. Stronger advocacy for income compensation for mothers to ensure that there's no compromise between healthcare and employment, and to build on existing programs to promote social care. So thank you very much for your participation. Thank you very much, attendees, for your questions. Sorry that we couldn't hear them orally. You will be able to view the recording of this session until the end of March. And if you have any more questions, please do contact our panelists and post your questions and comments. Thank you very much for this very enjoyable and thought-provoking session. Bye.
Thank you.
Thank you, JK. That was great.
Thank you.